Our last speaker for this section is Dr. Navneet Majhail. He received his medical degrees from the Government Medical College and the All India Institute of Medical Sciences, and went on to complete his internal medicine residency at the Cleveland Clinic Foundation. He completed his hematology oncology fellowship at the University of Minnesota, where he also earned a Master of Science degree in clinical research. He is currently the director of the Blood and Marrow Transplant Program at the Cleveland Clinic and professor at the Cleveland Clinic Lerner College of Medicine, and he also serves as the scientific director of the CIBMTR Health Services Research Program. His research interests include survivorship issues and late effects of transplant, and today he'll be speaking to us on managing menopausal symptoms in women and hormonal side effects in men. Please join me in welcoming Dr. Majhail.
Thank you. Good afternoon. And so I was asked to talk about what's hot in managing menopausal side effects in females and hormonal side effects in males. And I am not at risk for menopause, so I can only tell you what I've learned from my patients and from the literature. And I still have some ways to go before I hit the menopause. So that's not from any personal experience, but from what I've learned from my patients and my colleagues. So what I am planning to do today is talk about what is the physiology of reproductive aging, both in men and women. And then we'll talk about what are the risk factors and what are the management options for patients with premature ovarian failure or premature menopause in women and hypogonadism in men. So focusing first on women. As most of you might know, menopause is essentially normal physiology, and it's a decline in reproductive potential over time due to ovarian aging. After a girl hits puberty, there's a period of peak reproductive potential. Eventually, with time, there's a decline in fertility. The woman hits climacteric, where the period ceases, and there's a period of perimenopause, and then eventually menopause. And the period, and sometimes if you look at the literature or read about this, a term called menopausal transition is used, which refers to these two phases, the climacteric and the perimenopause. Now, the one thing you have to keep in mind that the ovarian follicles are the cells in the body which make most of the estrogen in women. And you are born with these ovarian follicles. You are born with what you have. The body doesn't make more. It does not regenerate them. And what happens over time essentially is these follicles decrease over time, and eventually when a woman hits menopause, they go down to zero. In uterus, a girl fetus has roughly 10 to 20 million of these follicles. By the time she's born, they're already decreased to around 2 million, and then they keep decreasing. By the age of menarche, they're around 500,000, and less than 1,000 by the time the perimenopausal symptoms start. So again, I think this is important to keep in mind as I mentioned, the follicles are the ones which mainly make the estrogen in these women. So this is a figure where we'll talk about the hypothalamic pituitary ovarian axis. So that is the hormonal regulation of the production of sex hormones in women. So the driver is the hypothalamus, which makes this hormone called the GnRH, the gonadotropin releasing hormone. And what this hormone does is it goes to the anterior pituitary and tells it to start making LH and FSH, luteinizing hormone and follicle stimulating hormone. What these two hormones do is they go to the ovary, to the ovarian follicle, and once the ovary and the ovarian follicles see these hormones, they start proliferating. So they start growing. And as they start growing, they're the ones which make estrogen. And gradually over a few days to a week or so, the levels of estrogen keeps increasing in the body. And eventually it reaches a level where it goes and tells the pituitary to shoot out a pulse of this LH and FSH, what is called the LH surge. And as the pituitary does that, what it does is it makes the follicle ovulate, and that is where the oocyte is, or the egg is released, and what's left off forms the corpus luteum. Now, around the same time, towards the second half of this cycle, the ovaries also start making progesterone, and after once this phase starts, the estrogen and progesterone and a hormone called inhibin, they go back and tell the hypothalamus to kind of stop doing what it's doing, to slow down a bit. And around the same time, what also happens, so when the body is making all this estrogen, the uterus is also proliferating. It's getting ready for the implantation of a possible embryo. So if implantation happens, so fertilization happens, an egg with an egg and a sperm, and an embryo is formed, it goes and settles down in the uterus, and then this whole hormonal regulation kind of switches to a different area of the body. But if that doesn't happen, that is when the progesterone is released. That is when the hypothalamus and the pituitary kind of stop making what these other hormones, the LH and the FSH, and that is when the uterine mucosa that has proliferated sloughs off, and that is what leads to a period essentially. Now, what happens in menopause is over time, as these follicles are decreasing in number, and as they're also decreasing in number, they're also decreasing in quality. So they are less and less sensitive to the LH and FSH. They're not making as much estrogen either. And as that happens, this whole kind of feedback mechanism loop gets out of whack. And what happens is there is no longer this negative inhibition that's going back to the hypothalamus and the pituitary and regulating the release of the LH and the FSH. And what's happening is, the pituitary, doesn't have this negative feedback loop, which is telling it to stop doing what it's doing. And as a result, the LH and FSH levels go up. So what happens as a woman goes through pre-menopause to perimenopause to finally menopause, there is an increase in these LH and FSH levels. Okay, and so it peaks, and as after a time, the pituitary and the hypothalamus gives up. It says, well, nothing is happening. I need to slow down. And what happens is these LH and FSH levels peak, and then eventually start coming down. They don't go back to the pre-menopausal levels, so they still remain high, but kind of it peaks and then it slows down and plateaus out. So I think this is an important concept to keep in mind, because it can help you when you do testing for FSH or LH. It can help you kind of get a sense of what the levels are and what's going on in that woman. So talking about what are the causes for premature ovarian failure in women who get a transplant. So again, conceptually, you can think of two things. One is if there's something wrong with the hypothalamus or the pituitary. Something happens where they stop making the GnRH or the LH and FSH. And that could be radiation to the brain, for example, sometimes with lymphoma or kids who have medulloblastoma or other diseases, they'll get cranial irradiation. Total body irradiation can cause that. Chemotherapy can cause that effect. And sometimes just kind of general chronic illness can also suppress the hypothalamus and the pituitary. What happens more often in our patients is a direct effect on the ovaries. So, exposure to TBI, chemotherapy, especially alkylating agents like Cytoxan, melphalan, busulfan, disease infiltration in some diseases like ALL or aggressive lymphomas. If women who are at an older age at the time of transplant or are post-pubertal, they're more likely to get ovarian failure after transplant compared to women or girls who get this therapy before they hit puberty. So again, I think this is how you can think about conceptually if you have a patient in front of you, what exactly might potentially be causing the gonadal failure. Because if it is more up here, there's a decrease in LH and FSH as well. The estrogen and progesterone will be decreased as well because the ovary is not making any, but there'll be a decrease in LH and FSH as well. So if you have a woman where the LH and FSH levels are really very low, they are below normal, and that is where you might want to think about, is there something going on in the brain that's causing these menopausal symptoms? But in the majority of our patients who, as I mentioned before, most of this is happening here in the ovaries. So in the majority of patients, you'll have a typical menopausal profile where the estrogen levels are low, and so and the LH and FSH levels are slightly or quite elevated. So one quick note on the role of radiation, because many of our patients see radiation during the course of the disease or transplant. And it's a complex interaction between their age, their site of the radiation, the dose, and the fractionation. In girls who get radiation to their abdomen and pelvis for a non-transplant indication, if they receive 20 to 30 grays, if they are prepubertal, roughly 1 in 4 will, or 3 out of 4 will get ovarian failure. And in girls who get this radiation dose after hitting puberty, a majority of them will end up getting premature ovarian failure. In the literature within BMT or transplant, with the myeloablative doses of radiation, most women end up getting premature menopause. And again, as you get older, you're more at risk. So if you're older than 40, even a dose of just 6 grays is sufficient to cause premature ovarian failure. So what are the clinical manifestations? They can be early, more immediate. These are symptoms such as vasomotor symptoms like hot flashes, insomnia, mood disturbances, irritability, depression, anxiety. These are more, these have a big impact on quality of life. And then there are some intermediate physical changes that happen after the estrogen levels have been low for a while. These can include urogenital atrophy, vaginal atrophy, stress incontinence, skin atrophy in general. And then there are some late medical issues such as osteoporosis, cardiovascular disease, cancers, and infertility that can happen in this setting. So how do you make a diagnosis? In women who have not had cancer or radiation or a transplant, in most women, once the median time to hit menopause is around 50 to 51 years. And if you have a woman in front of you, a patient who is otherwise healthy, doesn't have these cancer exposures, you don't need labs to make that diagnosis. A clinical diagnosis is all you need. So if somebody in the right age profile hasn't had periods for at least a year, that is sufficient clinically to make a diagnosis of menopause. Now, having said that, in the context of our transplant patients, very frequently, at least in my practice, I would advise drawing an LH and FSH, at least to confirm that is what the case is, because it is not unusual to have an extended period of amenorrhea after just having a transplant, for example. So that is where, at least in my patients, I think I would do some lab testing as well. Supporting laboratory tests are either FSH or LH levels. As I mentioned before, the FSH, these levels kind of have a trend where they peak and then slowly come down over time. In our younger patients who are sexually active, you have to think about pregnancy as well. I mean, I've had at least one patient who got pregnant at 9 months post-transplant. It's because in some patients, ovarian function is preserved, especially our patients who get a non-myeloablative or reduced intensity conditioning. We don't have any good data on what is the risk of ovarian failure in that setting, and I think that is where it is important to keep pregnancy in mind. If a young woman who is sexually active comes with a long period of amenorrhea. Prolactin and TSH, if you're thinking about something that's happening in the brain. So hypothalamic can cause amenorrhea as well. And if you have a prolactinoma, for example, in the pituitary gland, I mean, that is another thing you can think of depending on what the clinical profile is. So how can you prevent ovarian failure? There are two general approaches. One is pharmacologic, where you can cause reversible suppression of ovarian function using either oral contraceptives or GnRH agonists such as depolupron. Now, how depolupron works is not well known, but the thinking behind this is, so for the normal regulation of sex hormone production and function, you need a pulsatile release of GnRH by the hypothalamus. What these pharmacological measures do, especially the depolupron, it leads to a more steady state level of GnRH in the body, and that leads to a suppression of LH and FSH production by the pituitary, and that is what suppresses the ovary for a while, and that's supposed to protect the ovaries. But again, having said that, it's not well described as to what the exact mechanism of action is. Its efficacy is not proven, but I think very frequently we'll do this in our practice, especially in our younger patients who also have who are menstruating, because this also helps in slowing down the menstrual periods in the early post-transplant phase when they're thrombocytopenic. It's not much side effects, so again, I think we use it in our program mainly to suppress menses, but again, whether or not it preserves ovarian function still hasn't been proven yet. The other way is to physically protect or move the ovary. So, I mean, in certain settings, you might move the ovary to put it out of the radiation field, or you might shield the ovaries. We don't do that very often among our transplant patients because for a couple of reasons. Firstly, there's an urgency to move ahead. They are leukopenic very often. They are neutropenic. They are thrombocytopenic, and it's hard to take them to a surgery to physically move the ovary in general. And most of these patients are getting TBI or chemotherapy anyways, and I mean, moving the ovary into a more protective area doesn't make sense. So this is more for women who have a pelvic tumor and you want to move the ovaries out of the radiation field. Again, I haven't seen my radiation colleague do a lot of ovarian shielding either. And the reason for that is partly because for many of these diseases that we transplant for, there can be a potential for leukemic infiltration of the ovaries as well, especially ALLs, high-grade lymphomas, and that is why it's avoided. So how do we treat premature or menopause in our patients? So you have to think of two issues. One is symptom control, which has more of a quality of life impact. And then you also want to prevent and manage the long-term medical effects that come with a longer period without being with estrogen. So if my patient gets ovarian failure at age 30, for example, she has 20 more years of a low estrogen level that she's exposed to compared to a routine age of 50 or 51 when menopause happens. So she's more at risk for bone loss, cardiovascular disease, and all the other things for which estrogen is really essential in the body. And again, there's an option for hormone replacement therapy as well as a variety of non-hormonal therapies that are out there. And again, at the end of the day, you have to personalize your therapy based on what your patient wants, their age, how much radiation they've had, how long out they're post-transplant, for example. Hormone replacement therapy is very effective for managing vasomotor symptoms and genital atrophy. It's somewhat effective in the literature on depression, mood changes, and somewhat effective for symptoms of joint aches and pains. It is not recommended for cognitive issues, and it is not recommended for prevention of coronary artery disease. And in fact, there was a big study called the Women's Health Initiative many years ago, and at least using the preparation they used in that study, they found that women, and this is again older women, 50 or 45 and older, who are perimenopausal or postmenopausal, in that setting, the use of hormone replacement therapy was associated with a higher risk of stroke and MI. So that is where it is not recommended for prevention of coronary artery disease, even though estrogen per se is thought to be protective against that. Bone loss, it's used pretty often, but you have to keep in mind there are equally effective therapies like bisphosphonates that are available for bone loss as well. So at least in transplant recipients, there is no good data to suggest what to do in this setting, but if you look at experts and the consensus opinion out there, I think the general recommendations are in women who are less than 40 years, who are of age less than 40 at the time of transplant. Irrespective of symptoms, you should consider hormone replacement therapy at least through age 50 in that setting, and you may want to continue that in the right clinical circumstance. In women who are older than 40, you have to discuss individually with each patient and then decide what makes sense for that clinical, given that patient's scenario. So how can we give this therapy? Transdermal preparations are available as well as the oral ones. They have pros and cons. The transdermal preparations are more expensive, but they have less metabolic side effects such as liver toxicity or lipid profile effects that you might see with the oral preparations. Having said that, oral preparations are much cheaper, and also a lot of women prefer using an oral preparation over transdermal preparation for that matter. In women who have an intact uterus, it's important to add a progesterone because if you only give estrogen, it leads to proliferation of the uterine mucosa and eventually increases the risk for uterine cancer. Okay, so that's why it's in women with an intact uterus, it's really important to either use a pill or a patch, which is a combined estrogen and progesterone preparation, or on the other hand, add progesterone for the last 10-12 days of their HRT cycle. Systemic therapy with either a patch or the pill is usually fairly effective for women with urogenital symptoms. But again, if you have a patient where she is not keen on taking systemic therapy or cannot take it because of a contraindication and has a lot of vaginal atrophy, for example, you can use a local preparation to help alleviate those symptoms. The important side effects to consider are blood clots. So hormone replacement therapy just by itself can increase the risk of blood clots by 1.5 to 2-fold. And if there are other risk factors like indwelling catheters or a previous history of blood clots or other risk factors for thrombosis, that risk goes up quite a bit. As I mentioned before, cardiovascular disease, you want to avoid hormone replacement therapy. Again, women with a history of cancer of the uterus or breast cancer in the past, you want to avoid HRT. At least in the setting of a transplant, no major drug interactions with immune suppressants like cyclosporin, tacrolimus, MMF, because again, we always worry about that in our patients. Azole antifungals interact with everything, right? So, that is where it may increase estrogen levels as well. But having said that, I typically do not dose reduce or change doses of the hormone replacement therapy that we use in this setting. Just use what's usually recommended. In patients with extensive skin GVHD, you want to avoid the transdermal patch because it may not be absorbed effectively or maybe variably absorbed. And again, as I mentioned before, a caution in patients who are at risk for blood clots, as well as patients who have LFT abnormalities or are at risk for that. Non-hormonal therapy approaches can include drugs like SSRIs, Lexapro, Paxil, or drugs like Effexor or gabapentin. At least in trials that have been done in cancer patients, they haven't been shown to be as effective as hormone replacement therapy per se, but they do work in a subset of women. And if you cannot use HRT, it's at least worth exploring in that setting. There's no good evidence for most complementary therapies like soy, herbal treatments, acupuncture, and so forth. But having said that, if I have a patient who comes to me and says she wants to use a certain therapy, and I usually work with our pharmacist to make sure there are no major interactions. I usually tell them it's okay because most of them don't have any major side effects, and there are anecdotal instances where a certain thing might help a certain patient. So I think it's worth trying as long as you make sure there is no interaction of that supplement with immune suppression or other antimicrobials that patient might be on. So switching gears and talking about hypogonadism in men, or what is called the menopause, and there was a whole time cover story on this issue last year because it's evolved into a multi-billion-dollar industry because there are all these older men with low fatigue, low libido, low erectile dysfunction who like to try testosterone to see if that might help. So again, coming back to the physiology of sex hormone production in men. And it's kind of similar to what happens in women, at least mechanistically, as all these hormones go back and forth. So we have the hypothalamus that again makes the GnRH, which stimulates the pituitary to make LH and FSH. And the LH and FSH goes to the testes, where the Sertoli cells and the Leydig cells make testosterone and sperms. And there's a negative feedback where this testosterone kind of modulates how much of these stimulatory hormones are being made by the hypothalamus and the pituitary to make sure there's a constant level of testosterone in the body. Now, when you think about the pathogenesis of male hypogonadism, there can be one of two things happening. Again, similar to what happens in women. There can be what is called primary hypogonadism, which happens more often in our cancer patients and transplant recipients, where the issue is mainly in the testes. So either because of radiation exposure to the pelvic region, chemotherapy in general, use of steroids, chronic illness, chronic kidney disease, even GVHD, what might be happening is the hypothalamus and the pituitary are okay, but the testes are not making enough testosterone. And again, in this setting, what is happening is the brain is telling the testes to make more and more testosterone, but the testis is not functioning, and then that is why it's not making any. So that is why what you see here are low testosterone levels, but high LH and high FSH levels. So I think that is something you have to keep in mind. On the other hand, you have secondary hypogonadism, where the issue is more at the higher level, in the hypothalamus or the pituitary, and that is where the testes might be okay, but the brain is not sending enough signals to the testes to make more of these hormones. And that is where, along with the low testosterone level, you have low LH and FSH as well. So I think, again, that is where testing is more important in the context of men versus maybe women with premature menopause or menopause for that matter. Now, just a few words about testosterone physiology. Very small amount of it is circulated in the body as in a free or an unbound form. The majority of it is bound either to albumin, and the free and the bound fraction is what is available for the body to use. 45% is bound to this protein called the sex hormone binding globulin, or SHBG. And there is kind of a homeostatic mechanism where the SHBG can either let go of some testosterone or bind some more, depending on what is needed by the body. Now, what happens to this bound testosterone is it goes to the adipose tissue, where it's eventually converted to either androgens or estrogens, and that is what helps maintain and initiates spermatogenesis and sexual maturation at puberty and later on. So there aren't as many studies about male hypogonadism as compared to premature menopause in the setting of transplant or cancer in general. So its epidemiology prevalence is not as well defined. But it's been reported in roughly a quarter of men who get chemotherapy-only conditioning. And most likely in men who get radiation as well, TBI as well, the incidence of prevalence is likely a bit higher. One thing to keep in mind, these Sertoli cells, which are the cells which make the sperm, are more sensitive to radiation than the Leydig cells, which is where the testosterone is predominantly produced. So you might have a situation where the testosterone levels might be okay in men who are otherwise infertile. So again, I think something to keep in mind if you have a young male who is being worked up for fertility issues post-transplant. So symptoms and signs are pretty non-specific: low energy, low libido, erectile dysfunction. You can see small testes, you can see decreased muscle mass, you may see gynecomastia, but that is seen more often in boys who have hypogonadism and are not able to fully mature the sex organs before becoming an adult. At least in our transplant patients, it is not very often to see these issues unless the hypogonadism has been severe and has been there for a long time. For most of our patients who are early post-transplant or a few years post-transplant, you won't see these signs. They are again at risk for infertility and bone loss, and it's more important to check hormone levels in men when you're diagnosing hypogonadism, because these symptoms that frequently manifest are fairly non-specific. I mean, a lot of other reasons for having low energy level, low sex drive, and erectile dysfunction post-transplant. So you can check total testosterone levels, and you can check LH and FSH. And if you are suspecting that the sex hormone binding globulin levels may be off, then you might check those levels as well. So they might be low in the setting of obesity, or they may be very high in the setting of elderly patients. Again, the testosterone secretion by the body follows a circadian rhythm. So it's better to check it the same time of the day if you're if you're testing again and again. And usually a morning sample is preferred. And it is not unusual to check 2 or 3 levels, because a lot of things can cause variability in that levels that you're testing. So you might want to check it a couple of times before confirming a diagnosis of hypogonadism. So testosterone replacement therapy is indicated in men who have symptoms of hypogonadism and have the laboratory features to support it. So essentially low testosterone levels. And again, if somebody has normal testosterone levels, using testosterone, typically, I mean, it's not going to help them as much. And if you look at it might help their symptoms per se, but there are some risks associated with testosterone as well. So that is where you have to be careful. So there are several preparations available. So you can have long-acting intramuscular injections. You can have transdermal gels and implants. The oral preparations are usually avoided because they are metabolized in the liver very, very fast and quickly, and they can be hepatotoxic. The transdermal preparations are fairly commonly used compared to the injections. Again, I mean, that's what a lot of men prefer. You can start with a patch or a gel, which is kind of a metered dose pump, which gives you a certain amount that you can apply on the skin. You have to titrate. So what you can do is you can check a baseline testosterone level, start therapy, check it again in 2 to 3 months, and you may have to titrate the dose up to get them to a more therapeutic level that is more than 200. And once they're at a steady state, you can check it every 6 to 12 months or so. You have to educate your patients, because if they're using a gel or a patch, for example, they should try and make sure there's no physical contact with somebody else, because it's very quickly absorbed to the skin. So their spouse or even children, for example, you got to educate them that the testosterone gel that they have their own skin can be transferred to somebody else on physical contact. So you have to be careful about that. Side effects to be aware of: prostate cancer. So if somebody has a history of prostate cancer, you should not be using testosterone. Ideally, these men should have at least a PSA level and a digital rectal exam before starting testosterone, and at 6 months, and then at least yearly thereafter. Very often, I'll be honest, I skip the DRE, the digital rectal exam, in these patients. I'll just do a PSA. But then again, that's a risk you have to keep in mind. And if they're especially older, you might want to send them to a urologist, at least for a baseline evaluation and exam, before you put them on testosterone. Risk of DVT and PE, erythrocytosis, BPH, benign prostate hyperplasia, is a side effect of testosterone therapy, and also worsening of pre-existing sleep apnea. It does interact with CS and tacrolimus and can increase the levels. And so if you're starting somebody on testosterone and they're on immune suppression, you've got to be careful about those levels for CS and tacrolimus and watch them closely for a while. And it can increase the risk of steroid effects. So if somebody is on so what happens to the testosterone in the body is it's eventually converted to androgens and steroid hormones. So if they're already on prednisone, you might exacerbate some of their steroid-related side effects. And I talked about the secondary exposure about which you have to educate your patients. So to finish up here, just to summarize what we've talked about, women who've had a transplant, they are at risk for premature ovarian failure and menopause. It's not uncommon in that setting. Frequently, it's a clinical diagnosis. You do measure LH and FSH levels to confirm your diagnosis. And in transplant patients, women who otherwise have no contraindications and they are less than 40, it's okay to consider hormone replacement therapy in that setting. In men who have symptoms of hypogonadism, it's really important to confirm that with labs, testosterone levels, and if needed, LH and FSH. And you can consider testosterone replacement therapy in appropriate patients. I think for the management of these side effects, both premature ovarian failure as well as hypogonadism, I think it's nice to work with your colleagues from either gynecology or urology or primary care practice. And especially for kids, I think it's critical to have a pediatric endocrinologist involved in their care so that you can work with your colleagues collaboratively to provide the best care for these patients. So I think with that, I will end, and I am happy to take a few questions.
Hi, I'm a gynecologist.
Okay,
and
great.
I actually wanted to add to a couple of points that
Sure.
you made. Oral contraceptive pills are not known to preserve fertility, so you shouldn't think of them in the same way that GnRH agonists are. The timing of GnRH agonist administration prior to induction chemotherapy matters because there is a weak flare after giving GnRH agonists. You just should hold that in the back of your mind. If you replace someone with sufficient hormones to decrease hot flashes, you may cause, with that feedback loop, a lowering of the FSH and LH, and then measuring FSH and LH when someone is on hormone replacement therapy will not be accurate.
Right.
I personally, because I see a lot of congenital graft-versus-host disease, use an estrogen vaginal ring, and that can give local hormones in the genital tract. There are different doses, some of which the really low dose does not stimulate the uterus, but the other ones do, as projection, as you commented on. And there's a new menopausal hormone preparation that's been approved in the last 2 years that combines a selective estrogen receptor modulator and low-dose Premarin, does not have progesterone, does not stimulate the lining of the uterus. It's called Duave, and I have only started to think about using it in the context of transplant. And there was one other thing that I thought of, but I didn't write it down. So there, I just wanted to share those other little tiny nuances.
No, thank you for that. Those were very valuable teaching points. Yes. Claire had a question.
Yeah, I was wondering if you have any experience with taking testosterone to help support libido in women after transplant.
To help support?
Libido issues in women after transplant.
So the question is the use of testosterone to help support libido issues post-transplant. In women. In women, I have not used it personally. I mean, we have Dr. Stratton here. Maybe you could try and address that. I am lucky today because I have her here to help me out.
So I actually think you have to be really careful because they get metabolic syndrome, and if you're not going to follow them long term in terms of assessing their cardiovascular risk, it's potentially a problem. And it may be that genital graft-versus disease is interfering with this, so they really should be assessed. And one of the things that I had a poster on earlier this week was looking at labial fusion above the urethra. I have seen that to be where women have dyspareunia, which will influence their libido, absolutely. And they actually had a neurodermatitis because they had labial fusion. And so I think that those things all matter. It's potentially possible to think about testosterone, but I would look at giving them hormone replacement and addressing their fatigue and making sure that all of those other things are set before you rush to getting testosterone. So that's how I approach it.
Yeah. And I think with the testosterone, you also have to worry about longer term is the virilizing side effects of testosterone as well. So that's something you have to keep in mind. Other questions? Okay. All right. Thank you.